Good afternoon, our dear students. I'm glad to see you this year in our online educational process in Medical School of Karazin University. I'm glad to see and I'm glad to hear everyone who are connected to our lectures. Today is the first day of new academic year, and here today we have a today it is a day that we name here in Ukraine a Day of Knowledges. And usually in school, in university, in all educational institutes, it is the first day of academic year. That's why today with all Ukraine, we start to study in our medical school, in our department. But you know that according to war in Ukraine, we start in this semester completely in online. That's why our today's first lecture is online too. This year, you continue your study in internal medicine in fourth year. Previous year on third course, on third year, you had introduction that we named Propaedeutics of internal medicine. Where you learn and main moments in diagnostics of internal diseases and main moments in approach to the patient. And from this year, we start a complete cycle of internal medicine. This fourth year, it will include several cycles, several parts of internal medicine. First part, it is endocrinology. It is some separate part because it is a little bit different from other parts. It connected with the different fields of medicine, not just internal medicine. That's why even in name of your discipline, you can see internal medicine, including endocrinology, because it is such a separate part of internal medicine. And we're starting from the endocrinology. And after it, you will have this academic year several more parts. It is part of gastroenterology, part of pulmonology, and hematology. What you will study this year. Next year, you will have cardiology, rheumatology, and nephrology. It will be continue of internal medicine and it will be on fifth year. And now we're starting from endocrinology. And today we have a first lecture from the cycle of endocrinology. The main rules on my lectures, maybe you know from the previous year, they are the same in Propaedeutics of internal medicine. I meet you here. All my lectures will be according to schedule on this YouTube channel. For checking your presence and your interest of your lecture, I ask everyone to leave your name and to leave your number of group in the comments. If you have, I open chat in this stream. That's why if you have questions, if you have some comments, if you want to detailize something, you can write during the lecture in the chat. And in the end of lecture, I always leave time for some maybe conversation with you. If you leave some questions, some comments, I'm ready to answer it after the lecture. And if you work with the lecture future, because I leave all records on YouTube channel, if in future you will have some questions or I didn't have time to stop on some moments and it is not understandable for you, you have questions, you have some difficult moment to study, you can ask it here in comments. You can ask it as usual in our Facebook page of our department. There, me and all our teachers are ready for discussion, ready for feedback, and discuss some difficult moment to help you with some not understandable moments for you. Unfortunately, today, due to some, it is a first day, I have some technical moments. That's why I can't here show you presentation. Who needs the presentation? Please send me, ask me in comments. I will send you by email PDF of presentation. And today I will talk to you just through the camera. If you need notes, if you need a presentation, you can do your head notes during the lecture or ask me in comments for the PDF of presentation I will send you. Okay, let's start our working topic of our today's lecture. Topic of our today's lecture, it is diseases of thyroid gland. I told you that it is a part, and it is a big part of endocrinology cycle. For today, it is the most often disorders in endocrinology and one of the most often in general in internal medicine. That's why it is a very important and actual topic for you. Now, one moment, I open my presentation. Okay, plan of our today's lecture. First of all, we will give definition to disorders of thyroid gland. We will discuss epidemiology, mechanisms, classification, clinical presentation, diagnosis, treatment, prognosis, and prophylaxis of disorders of thyroid gland. And first of all, let's give definition. What is diseases of thyroid gland? Who don't remember, does not remember anatomy and physiology of thyroid gland? Please stop in this moment your recording of lecture and return to it, because without understanding of anatomy, without understanding of physiology and pathophysiology of thyroid gland, it will be very difficult for you to work with diagnostics and treatment of these disorders. That's why please return to it. I hope everyone is remembered. Okay, diseases of thyroid gland. It results from primary or secondary of autoimmune in 80, it is the most often cause, 80% of cases, or not autoimmune, it is 20% of all cases. That either stimulate the overproduction of thyroid hormones that we name with the term of thyrotoxicosis or hyperthyroidism, or cause glandular destruction and hormone deficiency. We name it hypothyroidism. That's why we have it to the opposite processes. It is overproduction of thyroid hormones, thyrotoxicosis, and hypoproduction, hypothyroidism. In addition to it, it can be benign nodules and various forms of thyroid cancer. They are relatively common and amenable to detection for physical examination. All of them have a large range of symptoms and affect all ages. Epidemiologically, it's not very connected with the age and suffer from disease of thyroid gland as young adults, as age adults, as children. And we have one more important term for today. I hope you already know it. It is goiter. Let's remind one more time what is goiter. Goiter, it's a word goes from American English, or goitre, it is a little bit other writing of this word from the British English. It goes from Latin word guteria or struma. It is a swelling of neck or larynx resulting from enlargement of thyroid gland that we name thyromegaly that is not functioning properly. Worldwide, over 90% cases of goiter are caused by uridine deficiency. It is a whole world. Let's discuss a little bit more about epidemiology. The prevalence of thyroid dysfunction in adults ranges from 1 to 10% in all adults in the world. You see how a huge prevalence of these types of disorders. Every 10 adult person is suffer from different form of thyroid diseases. About 200 million people in the world have some form of the thyroid gland. It is currently diagnosed. In the same moment, women are more susceptible than men. The male ratio are nearly 4 to 1. Female patients 4 times more often suffer from these disorders. If we compare ages of first manifestation of thyroid gland, I told you that it can be all ages, but more aged people are there a little bit more often suffer from this problem. Epidemiology according to different countries and continents. We can divide the rate of thyroid disorders in different countries. It is a little bit different. Usually it depends on uridine nutrition and according to level of public health and different government problems. Why this difference between countries and different geographical places? Because it is a different using of uridine. If I could have this lecture, for example, 30, 40 years ago, I can say you that regions near the seaside, they are less sensitive for this problem, and regions far from seaside, and especially regions in the mountains, they are much more sensitive and in much more higher risk of goiter and thyroid problems. Why it connected with uridine using in nutrition, uridine intake. But today, the most countries are implement the programs of implementation of uridine in nutrition through the salt. And most countries use iodinized salt in diet in usual using. That's why in most countries, these situations with iodine deficiency is compensated. And if you see epidemiology by years, you can see that during time and last years, in most countries, the iodine deficiency goiter is a much more rare disease than earlier. But unfortunately, we can't affect all thyroid problem just with iodine intake. Unfortunately, we get another problem that nowadays goes on the first place in all thyroid problem. And you remember from definition, for today it's nearly 80% of all cases of thyroid diseases. It is autoimmune diseases. And unfortunately, we can't affect them with iodine intake, and even the excess iodine intake can worsen autoimmune thyroid processes. Okay, let's discuss risk factors of diseases of thyroid gland. First of all, you remember it is gender, that women 4 times more likely than men in risk of thyroid gland disorders. Second, it is age. I told you that aged people, they are in a higher risk of starting of thyroid problems, especially autoimmune thyroid problem, usually in a risk age after 50 years. It can be personal history of thyroid disease, of course. If patient previously have some thyroid problem, even after successful treatment, successful compensation in future, this patient has much more higher risk compared to other people. It is family history or cases of thyroid problems in the nearest relatives. Remember from Propaedeutics, the family history we check from the parents, children, brothers, sisters. And okay, for thyroid surgery, it is a huge risk factor for hypothyroidism. It is one of iatrogenic, and unfortunately, it is often problem and often cause of hypothyroidism when it was caused by previous thyroid surgery. One more iatrogenic cause, it is radioactive iodine treatment. For example, patients have thyrotoxic causes, for example, due to autoimmune thyroiditis. Now I'll show you more about these diseases. It was prescribed radioactive iodine treatment, and like complication, it can be hypothyroiditis due to radioactive treatment. One more risk factor, and it is more usual, more often, it is cigarette smoking. It is strong risk factor for autoimmune thyroid disease. Moreover, I told you a little that it is using of iodine and supplements containing iodine. They lead to risk of autoimmune thyroid disease, as for hypothyroidism, as for hyperthyroidism. Moreover, on the opposite side, not just excessive iodine, but an iodine deficiency can lead to thyroid problem. That's why as excess as deficit can lead to thyroid problems. Some certain medical treatments and drugs like amiodarone, like drugs of lithium, or for example procedures like bone marrow transplant can lead to worsening of autoimmune process and diseases of thyroid gland. Using some foods like cabbage, Brussels sprouts, broccoli, turnips, rutabagas, kohlrabi, radishes, cauliflower, African cassava, millet, kale, and soy. This either in overdosing, of course, can lead to worsening of autoimmune process and thyroid gland diseases. Radiation exposure can increase the risk of autoimmune thyroid disease and thyroid cancer. Strong risk factor, it is distress. It can be neck surgery or trauma and other more rare factors. Okay, if we talk not about thyroid problems in general, if we talk about goiter, like morphological enlargement of thyroid gland, we can divide a little bit other separate risk factors. They're nearly the same with all thyroid glands, but in syndromes you can divide what is thyroid gland diseases in general, functional problems with hyper and hypothyroidisms, and separate morphological problem with enlargement like a goiter. And of course, the most often they are combined with each other. It can be goiter with hyperthyroidism or hypothyroidism. Both the situation hyper and hypo can be with normal size or even with decreased size of thyroid gland. That's why these syndromes can combine with each other. And you should remember one important thing that size of thyroid gland and function of thyroid gland, they are not connected with each other. They are not connection between them. What it means? It means that big gland like huge goiter can be with hypothyroidism or with hyperthyroidism or thyrotoxicosis, or with normal function that we usually name euthyroidism. Or, for example, normal size can have all three variants too: hyper, hypo, or euthyroidism. And small size thyroid gland can be thyrotoxic, can be can have hypothyroidism or normal function. That's why there is no connection between goiter and between function, but they can combine in one patient. Okay, let's return to risk factors. Risk factors separately for goiter. It is lack of dietary iodine, yes, iodine deficiency, thyroiditis. For it, it's very typical goiter. It is being female. It is age. It changes of developing goiter like enlargement increase with age, the same with the function. Personal or family history of autoimmune disease, the same. Here, important moment, it is pregnancy and menopause. They are in risk of goiter too. Certain medications like immunosuppressants, antiretroviral therapy, amiodarone and lithium drugs too. And the same with the other problem for goiter, risk increases with radiation exposure. Okay, etiology of thyroid gland problems. Diseases of thyroid gland sometimes result from inappropriate thyroid stimulation hormone levels or may be caused by problems of the thyroid gland itself. The common causes of hypothyroidism and Hashimoto thyroiditis, now we stop on it, uridine deficiency, pituitary and hypothalamus problems. A common causes of hyperthyroidism, it is a Graves' disease, toxic nodular goiter, toxic thyroid adenoma, and thyroiditis. All these forms we now, I'm going to stop now. And another etiology. Four types, it can be different types, usually four types of thyroid cancers. It is papillary, follicular, anaplastic, or medullary cancer, according to morphology of this cancer. Most of thyroid cancers are associated with radiation treatment to head, neck, or chest. Genetic mutations might be associated with thyroid cancer either alone or in conjunction with other types of cancer, like, for example, multiple endocrine neoplasia or different gene mutations like BRAF mutation. It is the most typical. Fix for yourself if you're interested in. Please read it at home, prepare to the practical classes, or let's discuss on Facebook. It can be other cancers like metastasis to the thyroid. The most often the lymphoma or breast cancer can give metastasis for thyroid gland. Etiology of goiter, like enlargement. Goiter refers to a condition where the thyroid gland is enlarged in size. Goiter can result from autoimmune Hashimoto and Graves' diseases, iodine excess and deficiency, and nodular thyroid disease. It is the most often situations for goiter. The most common cause for goiter is iodine deficiency, usually seen in countries that do not use iodized salt. I told you about it. In countries that are used iodized salt, for one of the first place to goiter goes selenium deficiency. For example, for Ukraine, if 20, 30, 40 years ago the first problem was iodine deficiency, for today selenium deficiency even more important in etiology structure than iodine deficiency. For today, it is a strong contributing factor. In countries that use iodized salt, the most often cause of goiter it is Hashimoto thyroiditis. I will stop on it more detailed. It is the most often form of autoimmune thyroiditis with hypothyroidism. Goiter can also result from cyanide poisoning. For example, in tropical countries, people eat the cyanide-rich plants like cassava root as a staple food. Mechanisms. Mechanisms of thyroid disorders are strongly connected with its physiology. Who don't remember regulation, please repeat for yourself it shortly. Yes, main function of thyroid gland it is producing hormones. We have two thyroid hormones like T3 and T4, or 3-iodothyronine and thyroxine. Their regulation, their secretion, regulates by pituitary gland that produce thyroid stimulating hormone or TSH that regulate with a negative feedback producing of T3 and T4. Negative feedback means T3, T4 higher, it decrease level of TSH. T3 and T4 lower, it stimulate more producing of TSH. That's why this opposite relation we usually name negative biological feedback. And pituitary gland has own regulation from hypothalamus. The hormone that regulate pituitary gland regulate production of TSH. It is thyrotropin releasing hormone or TRH that has own negative feedback with all other links. Okay, that's why mechanisms you understand that if it is primary problem in thyroid gland, for example, autoimmune process that, for example, decrease production of T3 and T4. What is go? It stimulate pituitary gland to produce more TSH to stimulate thyroid gland and compensate this deficiency. That's why in this case it will be progressive decreasing of T3 and T4 and progressive increasing of TSH. It is example of hypothyroidism. The opposite problem, for example, the same autoimmune process leads to overproduction of T3 and T4. Their increased level in blood decrease production of TSH in pituitary gland. That's why in this case it's typical progressive increasement of T3 and T4 and progressive decreasing of TSH. It is typical clinical picture and typical mechanism for hyperthyroidism. Let's talk a little bit on classification of thyroid gland. In international classification of diseases, you can find thyroid gland problems in chapter 4 that name endocrine, nutritional, and metabolic diseases. And it coded from E00 to E07. Please find this classification for yourself. All forms of thyroid gland disorders, you can put code in your case history according to international classification of disease. According to goiter morphology, we can classify goiter either as a growth pattern or size. According to growth pattern, we can classify goiter to uninodular goiter, can be either or inactive or toxic. When we have some local processes, some local, most often it is nodule, and all other tissue of thyroid gland is okay. And we have multinodular goiter when it is a lot of places, multi-local pathological morphological process. It can be likewise be inactive or toxic too, as uninodular, as multinodular can without affection of function, and toxic when this nodule produce a lot of T3, T4, lead to hyperthyroidism, to thyrotoxicosis. And another form, it can be diffuse goiter when it is enlarged but without any significant pathological locuses like nodules. No uninodular, no multinodular. It is diffuse enlargement. We name it diffuse goiter. And diffuse goiter we can classify it according to size. It can be class 1 size. When in normal posture of the head, it can't be seen or is only found by palpation, when we can find this enlargement by palpation. Class 2 size. The goiter is palpable and can be easily seen. And class 3 size, when its goiter is very large and is retrosternal, pressure results in compression marks. According to World Health Organization, goiter in general, not just diffuse goiter, all goiters, we can classify according to size. Grade 0, it is when no goiter presence is found. Grade 1, when neck thickening is present in results of enlarged thyroid, when it can be palpable, however, not visible in normal position of neck, the thickening mass moves upwards during swallowing. You can check it just with palpation. Grade 1, moreover, includes also nodular goiter if thyroid gland enlargement remains invisible in a normal neck position. And according to World Health Organization, it can be grade 2 when neck swelling visible when neck is in normal position corresponding to enlarged thyroid found in palpation. Classification according to type of processes, and here I want to stop in inflammatory forms of goiter. We can divide it on acute thyroiditis. Usually it can be due to bacterial infection, fungal or parasitic infection, and in immunocompromised host. It's not a very often forms acute, but it's enough often to see it in real clinic. You can meet it. That's why when you will study, when you prepare practical classes, please stop on this form. They are very typical for immunocompromised person. For example, for people with congenital immunodeficiencies or, for example, with AIDS. Subacute thyroiditis, it is quite common form. It can have granulomatous form or subacute specific subacute thyroiditis that we name Decker-Vance disease or Decker-Vance thyroiditis. It can be silent thyroiditis. It can caused by subacute lymphocytic thyroiditis and painless thyroiditis. Another inflammatory form, it is Riedel's thyroiditis. Another name, it is Riedel's struma or immunoglobulin G4 related disease. It is one of the manifestations on inflammatory chronic systemic multi-organ disease. It is multi-organ immunoglobulin G related disease. Palpation of thyroiditis refer to the development of thyroid inflammation due to mechanical damage of thyroid follicles. It can be repeated palpation or surgical manipulation of the neck area. That's why during all manipulations with thyroid gland, especially in goiter, especially in suspected thyrotoxicosis, it have to be very, very soft, very, very accurate, and very, very attentive. Okay, forms of clinical manifestation. According to what you see in the real clinic, what you see in a patient, you can see two forms of functional problems with hyper and hypothyroiditis. And clinically, you can see a goiter like enlargement of neck. Let's repeat. We talked a little bit about forms, but repeat more detailed one more time. What related most often to hypothyroiditis or decreased level of thyroid problems? First and most often, it is autoimmune form. It is Hashimoto thyroiditis. Moreover, to hypothyroidism can lead ORTS hypothyroiditis, postoperative hypothyroidism, postpartum thyroiditis, thyroiditis, acute thyroiditis, iatrogenic hypothyroidism, thyroid hormone resistance, euthyroid sick syndrome, hyperthyroidism. To hyperthyroidism, it leads thyroid storm. It is situation of emergency in hyperthyroidism. The most often autoimmune form. If for hypo it is Hashimoto disease, for hyper it is Graves' disease. It is autoimmune form of thyroiditis with hyperthyroidism. Moreover, to hyperthyroidism can lead toxic thyroid nodule, toxic nodular struma, or we name it Plummer's disease, or Hashimotoxicosis. It is what about functional disorders, hyper or hypo? What more we can see clinically? Clinically, we can see nodular abnormalities in the form of goiter. Of course, it's difficult to detailize clinically in objective examination that it is nodule, but with palpation and sometimes even invisible, you can suspect that goiter caused by nodules of thyroid gland. We can find goiter due to tumors. Here can be one more time thyroid adenoma, thyroid cancer, lymphoma, or metastasis from elsewhere. And deficiency. A congenital hypothyroidism with untreated can lead to such situation like cretinism. For today, it is a rare disorder, but possible. Okay, classification according to goiter morphology. Regarding morphology, goiter can be classified either as a growth pattern or as the size of the growth. Growth pattern, it is uninodular goiter, can be either inactive and toxic. Okay, we have this slide, sorry. Okay, clinical investigation. It was classification, the main forms. It was quickly, but I hope you make some notes, and at home you should classify for yourself just for understanding all these thyroid problems according to morphological forms, according to function, according to clinical manifestation. And let's start diagnosing. How to put diagnosis of thyroid diseases. As usual, the main part you remember from Propaedeutics, main part of diagnosis, it is objective clinical investigation. And for starting clinical investigation of patient with thyroid problem, you should know most common symptoms and signs of thyroid gland problem. Sure, you remember from Propaedeutics, difference between symptoms and signs. Who don't remember, please return to it. What main symptoms and signs we can find in patients with thyroid gland problem? It can be nervousness and tremor that usual for thyrotoxicosis. It can be mental fogginess and poor concentrations, can be for both as for thyrotoxicosis as for hypothyroidism. It can be menstrual changes, very often female sign and symptom, possible as for hyper as for hypothyroidism. For hypothyroidism, often sign it is a symptom. It is feeling bloated. For hyperthyroidism, typical sign it is racing heartbeat, but in some cases, please read more about it. It can be in hypothyroidism too. There, it is more possible. There are rare heartbeats with bradycardia, but in some cases it can be compensatory paroxysm of tachycardia and even arrhythmias. That's why don't think that raised heartbeat tachycardia is just for hyper, bradycardia just for hyper. Tachycardia can be episodically in a hypo too. That's why please clinically don't make mistakes. It can be aches and pains in a patient, possible in both form functional as for hyper and for hypothyroidism. For hypo, more usual weight gain. For thyrotoxicosis, more usual weight loss. For hypothyroidism, typical high cholesterol level. For hyperthyroidism, typical heat intolerance, and for hypo, it more typical opposite, feeling cold. Let's stop more on clinical symptoms and signs of hypothyroidism or low levels of thyroid hormones. One more time. It is coarse and dry hair. It is hair loss. It is confusion and forgetfulness, often mistaken for dementia in seniors. Increased menstrual flow in women. It is intolerance to cold temperatures, irritability, muscle cramps, slower heart rate with episodically possible tachycardias and arrhythmias. It is a very severe weakness. It is possible and often weight gain, constipations. Thyroid gland function of thyroid gland is affected in a high grade to emotional processes. That's why it's very typical some emotional and psychological changes in patients with thyroid gland problems, and especially for hypothyroidism, it is typical depression. Moreover, it can be dry, scaly skin, and it can be fatigue or feeling of sluggishness. And it's a very typical edema. I don't remember we talk about it or not. Most of these patients are adept. Severe form of hypothyroidism, the critical form we name myxedema. For myxedema, it's typical low body temperature, dulled mental processes, congestive heart failure, and in most severe cases, it can lead to emergency that we named myxedema coma, with a loss of consciousness, seizures, slower breathing that can either, without treatment, even can lead to death. Clinical signs and symptoms of hyperthyroidism. The opposite situation with the high levels of hormones. And mostly the opposite clinical picture. These patients are in the most characteristics are absolutely opposite. They have increased heart rate with abnormal rhythm and pounding, with palpitations, with high blood pressure, increased body temperature, and these patients usually feeling unusually warm. Patients feel increased sweating, clamminess, feel agitated and nervous if hypothyroid patient usually in depression. They are very slow, they are very depressed, they are suffering all the time about everything. This patient can be nervous, can be agitating, and even aggressive patient. Often a patient with hyperthyroidism has tremor in the hands. They have feeling of restlessness even though the person is tired or weak. They feel increased appetite accompanied with weight loss. They usually have interrupted sleep, frequent bowel movement, sometimes they have diarrhea, puffiness around the eyes, increased tears, sensitivity to light, or an intense stare. They have bone loss that we named such term like osteoporosis and stopped menstrual cycle. And we have a very specific sign that is very usual for patient, very specific, and it clinically bright. It's easy to suspect for you thyrotoxicosis just in one sign. This sign names exophthalmos. What is exophthalmos? It is deformation of eyes with movement there in a front when you can see all the round of eyes. And thyrotoxicosis has emergency situation too. In the most severe cases, it leads to life-threatening thyrotoxicosis or thyroid storm. It accompanied with confusion, coma, severe fever, high blood pressure, irregular heartbeat, which can be fatal, jaundice associated with liver enlargement, mood swings, muscle wasting, restlessness, shock, and weakness. Clinical investigation of hyper and hypothyroidism. During clinical investigation, objective examination, what can we find? For hypothyroidism, most often objective signs, it is dry coarse hair, loss of eyebrow hair, puffy face, enlarged thyroid, slow heartbeat, weight gain, constipation, and brittle nails. For hyperthyroidism, it is hair loss, bulging eyes, or exophthalmos, sweating, enlarged thyroid, like a goiter, rapid heartbeat, weight loss, frequent bowel movements, soft nails, warm, moist palms, tremor of fingers. And further signs and symptoms, it can be possible for both as for hyperthyroidism, and they can be accompanied both with arthritis, cold intolerance, depression, dry skin, fatigue, forgetfulness, heavy menstrual period, infertility, muscle aches, difficulty sleeping, heat intolerance, nervousness, irritability, muscle weakness, infertility, and menstrual periods. Symptoms in the neck and thyroid area. It is neck discomfort, visible thyroid enlargements or lump, discomfort with the ties, scares, turtlenecks or necklaces. Even female can, and male and female can't wear some tight clothes. Yes, that very tightly line on the neck, or even necklaces, some jewelries, or some ties or other clothes that are connected with the neck. Moreover, it can be hoarseness, sore throats, soreness in the neck, and difficulty swallowing. In some cases, thyroid disease and condition can have no thyroiditis. It can be unknown, these symptoms at all. It can be asymptomatic. Investigation of thyroid nodules. Nodules usually are found in 4-7% of all thyroid glands in all adults at all. The majority of nodules do not cause any symptoms. Malignant nodules, which only occur about 5% of nodules, include follicular, papillary, medullary carcinomas, and metastases from other sites. Nodules are more likely in females. There can be many nodules, which is termed a multinodular goiter, and this can sometimes be a toxic multinodular goiter. Clinical investigation of goiter. Goiter, which is associated with hypothyroidism or hyperthyroidism, may be present with the symptoms of underlying disorder. For hyperthyroidism, the most common symptoms are associated with adrenergic stimulation. How to remember this huge number of symptoms? Yes, hyperthyroidism, it is adrenergic symptoms with tachycardia, palpitations, nervousness, tremor, increased blood pressure, heat intolerance. And the clinical manifestations are often related to hypermetabolism, with increased metabolism, excessive thyroid hormones, an increase in oxygen consumption, metabolic changes in protein metabolism, immunological stimulation of diffuse goiter, and ocular changes with exophthalmos. For hypothyroidism, the most common symptoms are weight gain despite pure appetite, cold intolerance, constipations, lethargy that are often non-specific and make diagnosis difficult. That's why often hypothyroidism usually can be diagnosed very late because all symptoms are very non-specific. Okay, key step or diagnosis. First of all, it is as usual clinical examination and objective examination. It is complete patient history with anamnesis, with compliance, and according to symptoms, you can suspect hypothyroidism or hyperthyroidism, and objective examination when you can find all these signs that we talk about upper, and of course checking of thyroid gland with palpation, with visualization of it on the neck. As usual, it is the main thing in our examination. And when after objective examination, of course, you must have preliminary diagnosis, you can confirm or not confirm it with additional test. For thyroid gland, the main test will be blood testing and imagination and aspiration biopsy. In blood testing, the most important thing, it is TSH. You remember from pituitary gland, thyroid stimulating hormone at each level in blood. It is the most often test and a screening test for thyroid gland disorders. Even in most programs, it recommended for all people after 40, after 50 to do it once a year for screening of thyroid function problems. Additionally to it, for checking of thyroid problem, if we suspect it, we check free level of free T4 hormone, level of free T3 hormone, levels of antibody, testing to diagnose Hashimoto and Graves' disease, and testing for reverse T3 levels. Visualization or imaging test. Here we use radioactive iodine intake uptake test, computer tomography scans, MRI, and ultrasounds. Evaluate the size, shape, and function of thyroid gland. To evaluate the size, shape of the nodules and lumps, and evaluate whether or not they are suspicious for thyroid cancer and require further evaluation. And if during visualization we find some structure, tumors, nodules, lumps, cysts, something that need more investigation, we do it with a fine needle aspiration biopsy. It's done when thyroid nodules are considered suspicious or any other structures and need to be tested for possible thyroid cancer. For at any suspicious process, we always do biopsy. Okay, TSH testing. I told you that it is the most often and most important testing because it is the most sensitive and ambulatory population at risk for thyroid dysfunction. Among the individuals with serious acute illnesses, the serum TSH is less specific for thyroid disease because a serious illness alone can depress TSH secretion. When an abnormal serum TSH value is obtained as decreased or increased, the usual next step to repeat measurement of TSH and also measure the serum free T4 level. It goes up to TSH. The most common cause of discordance between TSH and free T4 result occurs in patients with subclinical thyroid dysfunction, the high allowed serum TSH values and normal serum free T4 result. Now I will stop on it one more time. Serum TSH measurements may yield mislead the result from the individuals with changing level of thyroid hormones. Hypothyroidism. The most often cause of clinical hypothyroidism, I told you, it is autoimmune disease that we name Hashimoto's thyroiditis or Hashimoto's disease. Other causes are radioactive iodine therapy and surgical therapy for thyroid glands. If previously it was radioactive therapy or surgical treatment, it often cause of further hypothyroidism. Hypothyroidism may occur rarely, less in like 1% of cases as a result of deficiency of TRH or TSH secretion, like a central cause, when it is all okay with the thyroid gland, but according to abnormal regulation, abnormality of pituitary or hypothalamus with abnormal TSH or TRH secretion, it can lead to secondary or tertiary hypothyroidism, but one more time, it's a rare case, less than 1% of all hypothyroidisms. People with a primary hyperthyroidism, the most often case, have high level TSH level, and the concomitant finding of low free T4 level confirms this diagnosis. One more time, what I explained to you about negative feedback, typical primary hypothyroidism. Yes, T4 will be low because it is hypothyroidism according to some cause, most often autoimmune, thyroid gland unable to produce enough hormones, enough T4. That's why it will be low. But according to hyperstimulation all the time, pituitary gland stimulate production of TSH level all the time. It gives us excess TSH level, and its level during testing will be increased. That's why fix for yourself negative feedback, typical primary hypothyroidism, low free T4, high TSH level. People with a high serum TSH concentration can have a normal or low normal serum T4 level. We named the situation subclinical hypothyroidism. It is a situation when it's starting some process, autoimmune or not autoimmune, with when a thyroid gland have problems with production, but according to oversecretion of TSH and overstimulation of gland, it's still able, like overstimulated, give enough level of T4. That's why it is a starting of disease, and we usually name it subclinical hypothyroidism. One more time, T4 normal, but TSH high, like more sensitive test. The diagnosis of secondary hypothyroidism, it is a rare case, I told you, but possible. It based on the findings of low T4 and normal or low TSH. When we don't see negative feedback as T4 as TSH low, first of all, we suspect secondary hypothyroidism problem in hypothalamus and TSH secretion. Okay, hyperthyroidism or thyrotoxicosis when it is excess of thyroid hormones. Most common cause it is a grave autoimmune disease with activation of TSH receptor resulting in stimulation of T4 and T3 production and enlargement of the thyroid. Other causes are multinodular goiter, thyroid adenoma, thyroiditis, uridine or drug-induced hyperthyroidism, and TSH-secreting pituitary tumor. The diagnosis is based on the findings of a serum free T4 level and low serum TSH concentration. Occasionally, patients with hyperthyroidism have a normal serum-free T4 and high serum-free T3 concentrations, with a normal the serum TSH. Patients with a low serum TSH concentration, normal serum T4 and free T3 level have subclinical hyperthyroidism. Okay, it was quickly. One more time, let's stop. Hyperthyroidism. If it is most often primary typical hyperthyroidism. Hyper, it means high, T4 and T3, but the most important laboratory for us, free T4. Free T4 will be high, and according to negative feedback, TSH will be low. It is primary hyperthyroidism. Subclinical hyperthyroidism, logic the same with subclinical hypo, when it is excess of free T4 with excess with the upper a subclinical hyperthyroidism when it is TSH is decreased but free T4 it's still normal. It will be subclinical form of hyperthyroidism, low TSH, normal T4. And when it is increased both as free T4 as TSH, we suspect secondary or pituitary problem with secondary hyperthyroidism. Okay, imagination. The most simple and the most useful and quite in most cases it is enough test for visualization. It is ultrasound of thyroid gland. On ultrasound, we can visualize nodules of thyroid gland. They may be cancer or maybe just nodules, like benign nodules. Medical ultrasonography can help determine their nature because some of characteristics of these nodules. According to picture, according to visualization of nodule, we can decide is it benign, possibly, or malignant. It's not complete diagnosis. For confirming it, we always need histological test, morphological test with, through the biopsy. But according to ultrasound, we can suspect is it benign or is it malignant. For malignant, typical characteristic, it is irregular border of this nodule. When the nodules are hypoechoic, it means less echoic than surrounding tissue. When it presents some microcalcifications in these nodules, when it's taller than white shape on transverse study, and when it is significant intranodular blood flow by Doppler. You remember we can such regimen in ultrasound like Doppler ultrasound when we can check a blood flow. And when the blood flow in the nodule very intensive, it is not a very good sign for malignancy. Okay, ultrasound or ultrasonography not always able to separate benign from malignant. It's just suspicion. In all suspicious case, what I told you, I tell one more time. In all suspicious cases, this tissue sample is often obtained by biopsy for microscopic examination. Okay. What else we can use for visualization of thyroid gland? Such tests like radioactive scanning and uptake, or thyroid scintigraphy. It is imaging of thyroid with the aid of radioactive iodine or iodine 123. Iodine that gives to the patient, it collects in the thyroid gland before being excreted in urine. A nodule that overactive or when it is simply clinically hot nodules to the point of suppressing the activity of the rest gland is usually for thyrotoxic adenoma, like for example in Plummer's disease, and surgically curable form of hyperthyroidism that is hardly ever malignant. Finding that a substantial section of thyroid is inactive and not accumulation of radioactive iodine, we name it cold nodules. They may indicate an area of non-functioning tissue, and it is a very suspicious sign for thyroid cancer. A normal quantitation of radioiodine uptake demonstrates that about 8 to 35% of all administered dose can be detected in the thyroid in 24 hours later. Okay, thyroid biopsy. A thyroid tissue may be obtained for biopsy by, I told you, fine needle aspiration or by surgery. Needle aspiration has an advantage of being a brain safe outpatient procedure that is safer and less expensive than surgery and does not leave a visible scar. You understand? To inject it with a needle and to make surgery with a cutting and taking sample. It is absolutely different things. That's why we use in most cases needle biopsy in control of ultrasound when we visualize where is suspected place, and from this place with a needle take a sample of tissue. The surgical way we use just through the surgery. For example, when surgeon do thyroidectomy and take the pieces of nodules for morphological examination during another surgery. Needle biopsy became widely used in 80s years of previous century, but it was recognized that accuracy of identification of cancer was good but not perfect. The accuracy of the diagnosis depends on obtaining tissue from all the suspicious areas from abnormal thyroid glands. You understand that we can't spontaneously inject some place of thyroid gland and they take their piece. We must take this piece, especially from this suspicious point, because malignant process can be in these points, and in 1 centimeter it will be no malignant process. That's why for confirmation we can go directly in a place when it is some process. And according to it, the reliability of needle aspiration very increased and last nearly 20 years. When this sampling guided by ultrasound, when we can visualize this suspicious place with ultrasound, and in the same moment take with the needle this biopsy. Okay, and we have small time for management. More information on practical classes. I stop on it very quickly. Of course, as usual, we start from lifestyle modification, and here I want to talk to you about key nutrients that is important in thyroid gland diseases. We talked a lot about iodine deficiency, that one of the main causes of thyroid disease worldwide, and it can be considered rare in a lot of countries since the last century, largely due to widespread of iodized salt. Yeah, that's why Phsical, that using of iodized salt are very important practice to decreasing of iodine deficiency thyroid disorders. In people with Hashimoto disease, iodine intake is contraindicated because the excessive iodine stimulate autoimmune antibodies. Moreover, here important vitamin D deficiency. It linked to hyperthyroidism, Hashimoto's disease, and particularly Graves' disease. The highest concentration of selenium, told about it, is found in the thyroid gland, and it is a necessary component of enzymes integral to thyroid function. And our practice show that most patients with autoimmune processes and with the goiter, we check selenium, they very often decrease, and we add selenium supplements to our treatment. And one more important nutrient, it is vitamin B12. Its deficiency is one of the risk factors of autoimmune thyroid disease. So it's important for dietitians of suggest patients with the thyroid diseases they have levels tested. Okay, food, supplements, and medication interactions. There are no specific food or dietary supplement for thyroid glands, just in confirmed selenium deficiency or B12 deficiency or iodine deficiency, we can add it, but not prophylactically, not in our country, and in most countries too. The medications can interact with the common nutritional supplements. Like, for example, calcium supplements have the potential interfere with proper absorption of thyroid medications. Coffee and fiber supplements lower the absorption of thyroid medications. Chromium picolinate, we can use it for blood sugar control and weight loss. It impairs the absorption of thyroid medication, and patients should take it 3 or 4 hours apart from thyroid medications. Some flavonoids in some fruit, vegetables, and tea may suppress thyroid function too. We discuss these vegetables. Yes, it is cruciferous vegetables like broccoli, cauliflower, cabbage release the compounds called goitrine when they are hydrolyzed or broken down. This goitrine can interfere with the synthesis of thyroid hormone that is usually conserved only when coupled with iodine deficiency. Heating cruciferous vegetables denatures much of all these potential goitrogenic effect. Soy, here is important, is another potential goitrogen that and is the isoflavonoids in soy can lower thyroid hormone synthesis. It is one of the food that patient with thyroid gland disorders can be attentive. The potential exception in millet, a nutrition gluten-free grain, which may suppress thyroid function even in people with adequate iodine intake. Exercise. With hypothyroid patients, exercise can help with weight gain, fatigue, and depression. That's why it's strongly recommended for the patient. Opposite with hyperthyroidism, anxiety and sleep disturbances are so common, and exercise will help to regulate both. A structured exercise program in patients with Graves' disease is showing dramatic improvement of fatigue levels. Significantly more patients are able to successfully stop taking antithyroid medications without a relapse. Since fatigue can be a barrier to exercise, it is recommended patients use pedometer as a tool for tangible source of structure and motivation. That's why fitness bracelets or smart watches are very useful for this patient for controlling and what is important for motivation of patient to do exercises or at least walking a lot, it with at least 10,000 of steps per day. Okay, drug management of hypothyroidism. It's treated with replacement of thyroid hormones. Here is very simple everything. When it is deficiency of hormone, we need replacement of this hormone. The most commonly prescribed thyroid hormone replacement drug is levothyroxine. Please write for yourself. Just one drug, main drug for hypothyroidism, and such a lot of questions about it, and even in CROC, a lot of questions about levothyroxine. That's why remember it for yourself. It is a synthetic form of thyroid hormone thyroxine. There is also a synthetic form of T3 hormone known as liothyronine that is sometimes added to levothyroxine for T4-T3 combination treatment. There is a hormone replacement drug called natural desiccated thyroid or thyroid extract. While it has been available for more than a century and is still in some countries used today, in our protocols it's absent. Hyperthyroidism or Graves' disease with excess of hormones. There are three key ways in a chronic hyperthyroidism and Graves' disease treatment. First way it is antithyroid drugs. Here, the main of them, it is metimazole, carbimazole, or propyluracil. That can slow down the thyroid's production of thyroid hormone. Another way, it is radioactive iodine treatment that given a single dose either in a capsule or drink. This shrinks the thyroid, slows down its function, and reverses hyperthyroidism. And third way, it is thyroid surgery through the thyroidectomy in some cases, especially for patients who cannot tolerate antithyroid drugs or pregnant, and when their radioactive iodine treatment is not an option. Okay, quickly, management of goiter. It's treated according to cause. If the thyroid gland is produced too much T3, T4, the treatment it is radioactive iodine treatment. If goiter caused by iodine deficiency, it is small doses of iodine in the form of Lugol's iodine or kalium iodide solution are given. If the goiter is associated with underactive thyroid supplements are used as a treatment. In extreme cases, partial or complete thyroidectomy is required. Thyroid cancer. It almost always involves surgical removal of thyroid gland thyroidectomy. For more aggressive types of thyroid cancer that may be followed by radioactive iodine treatment, ensure that all thyroid cells are destroyed, a process known as remnant ablation. Following surgical removal of the thyroid gland, patients are functionally hypothyroid and further require lifelong thyroid hormone replacement. Less commonly are the treatment including external beam radiation, chemotherapy, radiofrequency ablation, and percutaneous ethanol injections. It is rare but possible options. Okay, autoimmune management. I don't have time to it. It is ending of your lecture. In after the break, you will have another lecture. That's why I want to stop on it. It is a little bit several more moments about treatment of autoimmune process, but you can learn it individually by yourself. And if you have questions, if you have difficult moments in it, if you have moments in it, please ask me in the comments, ask me on Facebook. We can discuss it in some individual or group consultations. For today, that's all. Please prepare to the practical classes. One more time, who needs PDF of presentation, write me your email or some contacts. Where should I send it? I send to everyone. And I'm waiting for your comments, and as usual, please write your name and number of your group in the comments. Who listen in my lecture for our controlling of lecture attendance. For today, that's all. See you in 1 week. We will have one more very interesting lecture about diabetes mellitus. For today, that's all. See you. Goodbye.